Welcome you all to this second day of DAISICON. Now we will move on to the first session of the day, the free paper presentation. May I request Dr. E. Suresh, Dr. Vengo Jai Prasad and Dr. R. Balamurugan to take over the session, please. Thank you, sir.
Good morning. The topic I am going to present today is about the study of animal bites management in non-diabetics versus diabetic patients. So why animal bites are a greater risk for diabetics? In diabetics, there is increased risk of infection. Diabetes can compromise the immune system, making it more difficult for the body to fight off bacteria in dog's mouth that enters the wound. There is poor circulation in diabetes. It can hinder the wound's ability to heal and increase the risk of complications. Diabetic neuropathy, nerve damage can cause a loss of sensation. So diabetics might not even realize that they have been bitten or notice the injury until it becomes very severe. So there's a potential for diabetic shock. Diabetic injury can cause blood sugar levels to fluctuate, eventually leading to severe diabetic shock or even a coma. So background, rabies is an ancient disease. It's been with us for so long, but still it is relevant. It's 100% fatal if not treated. So if vaccinated, it is 100% preventable. Then every year in India, there is like about 18,000 to 20,000 deaths occur of rabies in India. And animal bites, around 20 million animal bites happen in India everywhere. And I think India is the 8 million doses of ARV will be required annually. And it's a big market by itself. Then aims and objectives of our study, why 100% preventable disease is causing so many deaths in India because of lack of awareness and non-compliance to ARV. Then how many patients are aware about the post-exposure animal bite management? Negligible. Then how many patients undergo the full course of PEP treatment? That depends on urban area, it will be different, rural it will be different. Animal bite management comparison between diabetic and non-diabetic patients, that is what we have done. So this study was done at an animal bite center in a secondary care hospital in Coimbatore, South India. This study was conducted from September 28th of 2023, which happens to be the World Anti-Rabies Day. It is celebrated on some Louis Pasteur's, I think the day he passed away, something. Then till the 1st July, which is Doctor's Day, BC Roy Day, his birthday. Then the study variables were included were age, then the gender and the history and the physical examination and animal bite management according to WHO wound category. Then the individuals who met the inclusion criteria were set for the study. Then all the data collected were eventually analyzed. So this is the classification of wounds, and treatment will be accordingly. This is the WHO classification. In category 1, if there's even if the animal touches or while feeding the animal, or if the animal just licks on a healthy intact skin with no open wound, and there's no documented contact of dog saliva, the treatment is actually no treatment they were told, but at least a thorough wound care, wound toileting, and the washing it for at least 10 to 15 minutes would be adequate. Then category 2, if the dog just nibbles the uncovered skin, or it licks on your broken skin, or a superficial scratch that doesn't break the skin, if that happens, means wound management has to be done and ARV has to be given. Then category 3, it's a single or multiple transdermal bites or scratches which penetrates the skin at any location, or if there's a lick over the mucous membrane, then we'll have to do wound management and give ARV and add rabies immunoglobulin along with it. Then tetanus prophylaxis and has to be given, and additional antibiotic cover, everything has to be given, has to be provided. So in the center where in our center where they did this, like totally 100 subjects were taken in the study from 2023 till 25, and 60 were male subjects and 40 were female subjects, and 60 were non-diabetics and 40 were diabetics. And in this, for all the 100% of the 100 subjects, they were wound treatment was done with the soap and water. They washed it with 15 minutes. They washed it with soap and water, and in that 80% of the people they took this this vaccine, this TCV 5 doses were given, and for diabetic patients 40% they took this vaccine, and non-diabetic 59% were given, and then this rabies immunoglobulin 60% took the thing. Then local application to the wound 40% they took that, and some who took this indigenous treatment like this chili, turmeric, or etc. That was 30% were like that. So, according to the study, there is a positive correlation between post-exposure prophylaxis and rabies prevention. Diabetic patients, they usually require extra care and wound management, and based on the glycemic control, the healing will be better. Then diabetic patients are more prone for animal bite because they go for walking, jogging, everything in the morning or in the evening when animals come out to bite. And we have proven that rabies is 100% preventable disease in our animal bite center in Coimbatore, even if they have diabetes. And so thanks to the Supreme Court judgment, that eventually the 3-judge bench said that the strays should be released after being vaccinated and sterilized, but added that the dogs with rabies or aggressive behavior should be immunized and kept in shelters. The court also has banned feeding of stray dogs in public spaces and ordered dedicated areas to be set up for the purpose. So thank you.
We'd like to know exact statistics you have, like how many with diabetes went on to, how did you split up the post-wound care? Like, how long the wound needed to be treated?
Sir, actually, we have to give the...
What was the class of the wound?
Sir, actually 3 classes were there. In that category 3, for that we give rabies immunoglobulin and this ARV.
How many
sir.
in class 1?
Class 1, class 2, class 3, sir.
Do you have the...
This one, sir. This one.
Yes. The numbers you took.
Yes, sir.
Do you have the numbers in class 1, class 2 and class 3?
One minute, sir.
I think they don't have the numbers.
Only based on that, you can tell
Okay, sir.
how long the wound generally takes to heal.
Yes, sir.
So unless you match those classes,
Okay, sir.
you cannot come to a conclusion.
Okay, sir.
Have you done that? No.
Sir, actually...
There's only 100 subjects, sir. But class 1 எவ்வளோ நாள், class 2, class 3 என்னென்ன எவ்வளோ இருந்தது?
Sir, actually most of the patients who come to our center, they were only in class 2, class 3 like
No,
that.
please, you need to document that. That's what
Yes,
I
sir.
said. Otherwise, a good presentation.
Yes, sir.
And I think it's a good time that where a lot of rabies-related deaths are happening.
Yes, sir.
You brought this study. Huh?
Yes.
Good. Good luck.
Thank you,
Thank
sir.
you.
Thank you, sir.
Next presenter, Rajkamal. Who is calling? Yeah, please go.
So, good morning all. Myself, Dr. Shobha. I'm the Clinical Research Coordinator of Dr. Ashwin Karpan. So, my topic is Insulin IQ, an interventional study among nurses in South Indian Tertiary Care Hospital. So, our need for the study is insulin remains the cornerstone in all the diabetes management, and nurses serves as the primary healthline frontier in caregivers, and their knowledge is very vital for patient safety and also to improve their efficacy. So, limited data is always available in the South Indian tertiary care settings. So, our hypothesis mainly shows that a structured educational program will significantly improve nurses' knowledge on insulin therapy regardless of their prior educational qualification or clinical experience. So, our main aim is to assess the knowledge of insulin therapy among the nurses and also to explore the association with qualification and the experience, and also assess the impact of educational programs. So, our objective is to identify the knowledge gaps for intervention, to implement structured insulin education, evaluate the intervention effectiveness, and to develop recommendation for nursing education. So, the study design that we have used is the prospective interventional study in the tertiary care hospital among 250 registered nurses. So, we have made the informed consent, and the statistics or descriptive measures and parity test non-parametric were also done. So, the flow of study showed that first we have taken 250 registered nurses among our hospital, and then we have given a set of structured questionnaire to them and asked them to fill it. It was like a pre-test, and then we have given an education program. After giving the education program, we have done a post-intervention, where in the post-intervention, we got only 207 nurses who completed the examination, and then the statistical analysis were done and we have found the results. So our result for phase 1, this is the pre-intervention results. This has shown that 80% were females, and you can see the graph there. The percentage has shown like 50 to 55% were having the excellent knowledge. And then we have categories like good and moderate also. So no statistical significant correlation was found between the knowledge and qualification or with the experience. So this is the phase 2 post-intervention result. This is after giving the education. So we have made a education program in between with the diabetic educator, and after conducting that 2 weeks gap, we have taken the next examination. So in this, 207 nurses have completed both the examinations, and we have seen the improved graph. That is, this blue color shows the pre-test and the green one shows the post-test. So the post one have shown that 70% improvement in the nurses' insulin education knowledge. So the education intervention benefited all the nurses equally, regardless of their prior experience or the qualification. So our summary and conclusion tells that the educational intervention has significantly improved nurses' knowledge and insulin therapy with the scores that has been shown the increased variation before slide. The proportion of nurses with excellent knowledge also has increased from 53% to 70%. With moderate and basic categories also changed from 16% from 2. The intervention was equally effective across all the nurses regardless of their educational qualification or years of clinical experience. The study also demonstrated that structured education program can effectively address knowledge gaps on insulin therapy. That's very important to improve the patient safety in clinical settings. So the future prospects, what we are thinking is like, the education model can be expanded to other healthcare facilities and adapted to different health clinical settings to improve the diabetes care standards across institutions. And also the long-term retention. Future studies across the long-term distance like can be for 6 months or 12 months so that it can improve the patient safety, whereas their knowledge will also be improved. So the clinical outcomes, research is also needed to correlate improved knowledge and measurable patient outcome such as reduced medication errors, hypoglycemic events and improved glycemic control. So continuous education is vital for maintaining high standards of patient care and safety in diabetes management. So the recommendations what we are going to provide here is, first we have to standardize the education. We have to integrate the structured educational program into mandatory onboarding and annual training for all the nursing working staffs in the and the diabetic patients. With training champions, like train the training. That is, in each ward we will have a trainer. So that person will be like senior of the other nurses where they can help them immediately whenever their help is required. Monitor the outcome. Continuous tracking of clinical indicators like insulin errors, hypoglycemic events, glycemic control to correlate educational outcomes with patient safety measures. And then regular assessment. We have to implement periodic knowledge assessment to identify ongoing learning needs and ensure retention to critical insulin management concept. And blended learning. Adopt a blended learning approach combining online modules with targeted face-to-face sessions to maximize engagement and knowledge retention. Multidisciplinary approach. Expand the educational initiative to include all healthcare professionals involved in diabetes care to ensure consistent knowledge and practices. That's what. These are our references. Thank you, sir.
You are?
Myself, Dr. Shobha.
You a medical doctor?
No, I am from the clinical research coordinator.
What was the questionnaire you gave?
We have given a set of questions like what are the long-acting insulin, what are the short-acting insulins.
Do you have a copy of it? Can you put it?
Currently,
Has it been, is it a standard questionnaire recommended or authorized by any other forum?
Yes, sir. We have taken the standard questionnaires
Or from
and we
where?
have
What is the reference?
references. I can
this,
provide the
from-
questions later, sir, if required. Because we have provided the questionnaire and we have validated with
No,
our doctors
I
itself.
do get that, but what was the questions? Because it is highly variable. A certain hospital would have a certain set of patients where the knowledge base should be different.
Yes, sir.
And the other hospitals may need some other category of knowledge.
Yes.
So the questions that you are giving may not be suited to that particular patient.
Yes, correct, sir.
And the findings cannot be biased on that. Sorry, based on that. One. Number two, what was the mode of teaching you gave?
Through diabetic educator, we have given the demo session, sir. Like
How many hours and what was the base on that?
1 hour, sir. Per week, 1 hour. For
many
total
weeks?
of 3 weeks, we have given the session. We have separated them into 5 batches, sir. It was actually 250 members. We have separated them into 5 batches and we have given 3 sessions each of them.
So, exactly what was the content?
Actually, what we did is like, we have asked the general questions based on the short acting, long acting and the storage, everything, how you will be handling. So in that questions itself, we have got like, many were answering like, if the temperature comes around 2 to 8, some are answering like 3 to 5, like that we have given the choose the questions only. So they have given the wrong answer. So what we did is like, with the help of diabetic educator, we just gave the education and then we gave the post-intervention study. Is it a MCQ type? Yes, MCQ type questions.
What is the novelty in this? Everybody knows that you teach somebody something, they will be able to do it better.
But nursing and all, like we are not taking care of them so properly. So we just want them to know more about the knowledge. Because we were like, when they're giving the proper insulin counseling to the patient also, we want that to be effective. That's what we wanted to train them, sir.
Anything more? Okay, thank you.
Yes, thank you. Provide us the questions. Okay, sir. I'll try to give it, sir. Thank you, sir.
So, respected judges, senior doctors and friends, at the outset, I sincerely thank for DAISICON for giving this wonderful opportunity to present a short study on the practical tips for recognizing and addressing the insulin inertia at the primary care level. So, this short study was done to establish a clinical practical guide for primary care clinicians, practitioners, so managing patients with type 2 diabetes. So this presentation provides evidence-based strategies to identify and overcome the therapeutic inertia in insulin initiation and intensification. So the clinical challenge, why insulin inertia measures. So what's the rationale of this study? So despite clear clinical guidelines, many patients with type 2 diabetes, they remain suboptimally controlled due to delayed insulin initiation. So clinical inertia affects up to 60% of patients who meets the criteria for insulin therapy, leading to prolonged hyperglycemia and increased complications. So what's the hypothesis? It's a systemic identification of the barriers combined with structured intervention protocols with reduced insulin inertia by 40% with the things. So the primary objective was to identify the predictors of insulin inertia at the primary care level and developed a practical screening tools for the clinical use and test effectiveness of the things. So this is the study design. So it's a single center observational study, more than 847 patients with type 2 diabetes. So the data was collected based on the questionnaires and the electronic health record analysis, and a questionnaire was given based on the idea of things, and patient interviews and tracked insulin rates, other things, and it was followed up over a period of 18-month thing. So implemented standardized screening checklist, provided decision support tools, patient education materials and structured follow-up protocols, and it was statistically analyzed with multivariate logistic regression to identify the predictors. So this was the insulin initiation questionnaire which was given to the patients in the regional language in Tamil. So just 5 important things. How do you feel about starting insulin, and what's your main concern about the insulin, and do you feel confident that you learn to inject insulin yourself? Lastly, what kind of support would help you most in starting insulin? So this was the key findings before starting insulin. So what was the insulin inertia patterns? So the first thing was surprisingly the provider hesitation. Nearly 68% of the delays attributed to the provider concerns about the hypoglycemia, weight gain or treatment complexity. Secondly, the patient factors, like what we all know, 54% of the patients, they express the fear of injections, lifestyle concerns and misconceptions. And only the last thing was 42%, the system barriers, the workflow inefficiency and other things. So this is the clinical outcome in the impact of intervention. So how insulin initiation rates over the period of time, this structured intervention protocols, when it was followed up over a period of 18 months, nearly doubled the insulin rate with more improvement occurring in the first 6 months. So nearly 47% significant decrease in the time from indication to insulin initiation. Secondly, 1.2% HbA1c improvement in the period of 12 months. And lastly, the provider confidence. So clinicians reported increased comfort with insulin management. So what was the practical implementation tools which we used at our clinic setup? So first, any patient who was HbA1c greater than 8.5%, symptomatic hyperglycemia, progressive beta cell function, contraindications to other therapy. So this are the patients who have been needed for insulin. Secondly, just give a patient a written thing, your diabetes medications are working out, but your blood sugar show we need additional help. So insulin, what is insulin and why it is needed, and it's not a sign of failure, it's the next step in taking care of health. And lastly, the stepwise approach. So assess the readiness and address the outcomes, start with a long-acting basal insulin, titrate weekly based on fasting glucose, and lastly, add mealtime insulin. So this was the practical implementation tools. And summary is, insulin inertia is a modifiable barrier to optimal diabetes management, and early initiation prevents the microvascular complications we all know, and success requires providing the patient and the system level barriers simultaneously, and simple tools integrated with the existing workflows show greater sustainability. So long-term outcomes and complications and cost effectiveness of the evaluation and technology enhanced decision support systems are available, and patient reported outcome measures and quality of life will be improved. So these are the references which I used. The questionnaire was taken from ADA thing, and other things were used based on the references. Thank you for that.
Balaji, this is you said that you have taken patients with a progressive decline in beta cell function, and also you said the contraindications for the oral medication. Can you just say, how did you assess the progressive decline in the, what
So
basis? Progressive decline?
The patients
what
who
parameters?
So parameters is only thing is patients who have been started on the oral antibiotic therapies, long-term duration of diabetes more. So we all know that at the time of diagnosis, nearly 50% of the things.
No,
we didn't
that's right.
have any
History is
specific
fine,
things.
but what were the, did you assess by any laboratory
No, sir.
parameters?
No.
doing
This
a
was
C-
just a short survey of the
C-peptide,
things. No, sir.
C-peptide, did you do?
No, sir.
You didn't do. What contraindications for oral therapy you have taken in patients? You said contraindications, one of the criteria.
So contraindications to start insulin, sir. The patients, other contraindications like patients, other than the patient barriers, what are the things?
I don't think there's any absolute contraindications to start insulin therapy in a diabetic patients.
Any intervention, you said intervention, to whom is it for providers or you are addressing the patient concerns?
Sir, mainly to the providers, sir. So, and also to the patients, we gave some protocols like that written statement like about insulin, what it is and other things.
Provider means it has,
The staffs and other
treated
things.
with other doctors.
No, sir, no. It was purely a single center study. It was just a survey based on the delay, why the patient is not accepting the insulin and what's the delay in starting the insulin in spite of the need of insulin.
The questionnaire was given only to the patients.
Yes, sir, absolutely.
Then how did, based on questionnaire given to patient, how did you assess that the provider was hesitant to start insulin?
No. Provider
you
is
know
me,
that?
sir. It's thing. The provider is only the me.
Sir,
It was a
can we
single
go to the slides behind? If it is a single, please go back. If it is a single center study, how did you derive at the numbers? Go back, sir. 58% was the number you gave. Yes, next slide. 68% of the delay, how did you derive at that number, sir?
The thing is,
With a
68
single man, you did not
delays
compare with anybody.
attributed to provider concerns about hypoglycemia, weight con treatment.
How did you find out, sir?
Sir, the thing is, when we say about start a patient
No,
to...
in this study, sir, how did you derive at that number?
So it was a calculated thing, sir.
You are the only person.
Yes, sir.
So
Balaji-
you were hesitant to start insulin 68% of the time.
Yes.
Why is that so? That cannot be calculated with a single person. You will have to have certain number of people, and out of which you have to derive this number. If you are the only one person, it is 100%. Either you do
Not
it or
at
you don't
every
do it.
time we will not have some hesitancy to start an insulin, no.
So this is taken from the patient's questionnaire, and you said the provider, you said 68% delay. How does the patient say that the doctor is not initiated? Because you can only say, doctor வந்து எனக்கு இன்சுலினே இப்போ இனிஷியேட் பண்ணல, நான் எனக்கு தேவைப்பட்டது அப்படின்னு சொல்லி பேஷண்ட் சொல்ல முடியுமா?
இல்லை அந்த கொஷனர்லேயும் அந்த மாதிரி ஒரு கொஷனும் இல்லையே டாக்டர் எனக்கு இஃப் யூ கேன்
இல்லை சார், கொஸ்டினரில் வந்து வாட்ஸ் ஆர் த கன்சர்ன்ஸ்
இதில் டாக்டர் ஒரு மேலே எந்த விதமான பிளேமோ இல்லை கம்ப்ளைண்ட்டோ எதுவும்
இல்லை த திங் இஸ் ப்ரொவைடர் டிலேன்னு எதுக்கு சொன்னேன் அப்படின்னா certain patients we will not start an insulin in spite of என்னென்ன இப்போ patients வந்து they will come with, they will say that they were not interested to start an insulin. கேட்காம சில பேஷண்ட் நம்மளே ஆரம்பிச்சிருக்க மாட்டோம். அதே மாதிரி பேஷண்ட்ஸில் தான் நான் வந்து அந்த ப்ரொவைடர் டிலேன்னு சொன்னேன். எல்லா பேஷண்ட்டுக்கும் என்னன்னா ப்ராக்டிக்கல் கன்சர்ன் பெரிஃபரல் செட்டிங்கில் உட்காந்துருக்கும் போது
அது உங்களோட ரெக்கார்ட் பார்த்து இது பண்ணுறேன்.
அதுதான் சார், பியூர்லி என்னோட இஹெச்ஆர்லேருந்து எடுத்தது தான். ஸோ இட் வாஸ் அதை வச்சு தான் நான் பேஸ் பண்ணி இத்தனை பேஷண்ட்டுக்கு எவ்வளோ இது பண்ணணும், எப்போ டிலே, என்ன டிலே ஆச்சு அப்படின்னு எடுத்தது தான் சார். என்னோட இஹெச்ஆரில் வச்சு அதில் உள்ள ஃபாஸ்டிங் சுகர் என்ன ஹெச்பி1ஸில் இது பண்ணுது அப்படிங்கிறத வச்சு கால்குலேட் பண்ணேன்.
Two things you have done. One, you said you are taken from UHR. Other thing you are saying you use this questionnaire.
சார் நான் இனிஷியல் இதுலேயே சொன்னேன்னா ரெண்டுத்தையுமே கோரிலேட் பண்ணி தான் பண்ணேன். நாட் ஒன்லி த இஹெச்ஆர் அண்ட் கொஸ்டினர், ஐ கேவ் த கொஸ்டினர் டு ஆல் த பேஷண்ட்ஸ் and it was manipulated with the EHR what I am using.
Then how did you address that provider hesitation, sir? Yourself is a provider.
Yes.
Then you yourself addressed the issues.
It's only a calculated thing.
What was the intervention to you? What did happen to you?
Not based on a provider intervention. எனக்கு ஒன்றும் புரியல. Patients ஓட concern was
for a training or something after that?
Not, sir. Only thing is based on the patient survey, the improvement was calculated.
Thank you, sir. Thank you, sir. Nice.
Good morning. I'm Anlakshmi from PharmD intern from School of Pharmaceutical Sciences, Vistas. This is my cross-sectional study on serum uric acid to HDL cholesterol ratio as a predictor of poor glycemic control and cardiometabolic risk in type 2 diabetes mellitus. Now, this study was conducted because there is limited evidence in the Indian diabetic cohort. The serum uric acid to HDL cholesterol ratio combines a pro-oxidant marker and an anti-atherogenic lipid measure and may reflect metabolic dysfunction more robustly than individual markers. So the need for the study, the UHR ratio serves as a composite index of risk capturing oxidative stress and lipid imbalance that HbA1c alone may not indicate. It helps identify hidden cardiometabolic risk even in patients with normal HbA1c, offering incremental prognostic value in predicting poor outcomes. Since it is a part of the routine lab test, there is no extra cost burden, so it makes it a simple and inexpensive marker, especially in limited resource settings. So the aim is to evaluate the association of serum uric acid to HDL ratio with glycemic control and cardiometabolic risk in patients with type 2 diabetes mellitus. And the objectives are to compare UHR in patients with good versus poor glycemic control, to assess correlation of UHR with cardiometabolic indices, and also to identify a potential UHR cutoff, predictor of poor glycemic control. So this is a retrospective cross-sectional comparative study which was conducted in 370 adults. The population was classified into two categories, good control and poor control. And if patients over 18 years of age and with confirmed type 2 diabetes mellitus were included in the study, and patients who had readily available HbA1c, serum uric acid and lipid levels are only included to ease the burden. And for exclusion, people who had gout or hyperuricemia were excluded, and then patients with CKD in stage 3 or above stage 3 were also excluded, and patients on urate lowering or lipid lowering drugs were also excluded. Patients with acute illness, severe liver disease or pregnancy were also excluded from the study. And data collected, HbA1c, baseline demographics were collected along with HbA1c, serum uric acid and lipid profile. We also calculated derived indexes like UHR, TG, triglyceride to HDL ratio, AIP, which is the atherogenic index of plasma, and also castellate risk indexes 1 and 2, and also the remnant cholesterol levels. Coming to the results and discussion, baseline demographics, the two groups were comparable in terms of age, sex and duration of diabetes. There were no significant difference. Coming to the glycemic status, HbA1c was significantly higher in the poor control group. It was statistically significant. And coming to the lipid and derived indices, patients with poor control had higher UHR, TG, HDL ratio, AIP, castellate risk indexes and remnant cholesterol compared with good control. And all of the differences were statistically significant. So as we can see in the table, all the derived indices were elevated in the poor control group. And coming to the correlation of UHR with HbA1c, it showed a moderate positive correlation with HbA1c. The p-value was less than 0.001 and was also associated with triglyceride to HDL ratio and also AIP. So there are basically two questions that we also like to answer. How well does this marker distinguish between both the groups? So we did a ROC curve analysis for this, and it showed that UHR had the highest predictive value among the other lipid-derived indices with the cutoff of 0.25. Now I would also like to disclose that the cutoff is preliminary since it's a retrospective study. We need a prospective validation to confirm the cutoff. And then coming to the question, is UHR an independent predictor of poor glycemic control? Were there any other confounders? We have done logistic regression analysis. On univariate analysis, UHR was significantly higher in the poor control group. On multivariate analysis, UHR independently predicted poor glycemic control even after adjusting for other confounders like AHX and other lipid-derived indexes. Other indexes were also significant, but they were weaker predictors than UHR. So this shows that UHR was a very good marker. Summary, patients with poor glycemic control had significantly higher UHR and adverse lipid indexes. UHR correlated positively with HbA1c and cardiometabolic blockers. The ROC analysis also suggested a cutoff of greater than 0.25 as a very good marker for predicting poor control. On regression, UHR independently predicted poor control. Now this study concludes that UHR can be used as a simple, inexpensive and clinically practical biomarker to identify TDM patients with increased risk of poor glycemic control and cardio complications. However, coming to the limitations, there is no anthropometric assessments like waist, circumference, etc. in the study, and there is also no measure of ApoB because it is not easily available in low resource settings. And the study would also need a prospective arm to validate the cutoff from ROC analysis. Thank you.
Doctor, you said, you talked about the triglyceride as well as you had the index of uric acid triglyceride. Already it has been established that the hyperuricemia itself is an independent cardiovascular risk factor. That's one. Second, we see in any patient with an uncontrolled diabetes, the triglyceride most often, we find the triglyceride is in excess, especially if there is an insulin deficient. So these factors are already known. Now you're created a ratio and try to say that is a glycemic. What is the unique about it? What is the uniqueness of thing?
It is already known in diabetic nephropathy, sir, but the data in Indian diabetic cohort is very limited. So we're just trying to fill the gap, the research gap in the Indian population. We know that UHR is a biomarker for diabetic nephropathy. When we went through the literature, we identified that there was more data in Chinese cohorts than Indian cohort. So we tried to fill the research gap in a low resource setting hospital.
Did you exclude a patient with diabetes and gout?
Yes, sir. Excluded, sir.
Diabetes and gout, you said?
Yes, sir. It's excluded, actually.
No, you said. But why did you do that? Because, diabetes and...
Not diabetes, sir. Gout and hyperuricemia.
Yeah. That's what I'm saying. Is the diabetic patient with gout are excluded in the study?
Yes, sir. Yes. It is not mentioned here, but with gout, we are excluded.
Why?
Because it can alter the uric acid levels. It can alter the uric acid levels.
Basically, you're looking at only the biochemical parameters and done the study.
Yes.
You not try to compare with the clinical scenarios. You just try to make an analysis based on the triglyceride and uric acid. Then why you specifically excluded gout?
It can act as a confounder, sir, and it can affect the results.
Gout is a combination of a biochemical as well as clinical manifestation. Okay.
But it can affect the serum uric acid levels in the LFT, sir. That's why we have...
Any other markers, CRP, hypertension, CAD? Have you seen any other?
We have seen other derived indexes, sir, and also there is ApoB and then anthropometric measurements. We have not included it because we want to keep it ineffective and simple and something that is available in the low resource setting.
Anthropometric measurements are very simple only.
Can we go to the first slide, please? See, the topic tells me that UHR is a predictor of poor glycemic control. Where is anything on that?
So we have correlated it with HbA1c, sir.
It is just an association. How can you predict?
That's why, sir, we are only talking about association.
An association.
Yes, sir.
You cannot predict poor glycemic control with UHR. And even in your outcome, It has been very, you have presented that it is a predictor of poor glycemic control, number one. It is just an association, it's not a predictor. Okay. And have you taken into account the drugs that the patient is getting?
That's why we excluded patients with urate lowering, patients on urate lowering
Not
therapy.
only urine, urate drugs, the drugs on the diabetes,
Aspirin also causes
confounding drugs.
Yes.
You have not taken into account on the pharmaceutical side. And number three, like, what is the use of UHR in predicting poor control? Because uric acid 200 rupees, you want to be cost effectiveness, that is your aim. So uric acid you do it for around 200 to 300 rupees. Added on to that you do a lipid profile that will be around 600 rupees, comes to around 900 rupees. But you do just HbA1c, it comes only to around 400 rupees. HbA1c is cheaper than a UHR ratio.
Okay.
How do you say heightened cardiometabolic risk?
You have not followed it up. There is no cardiometabolic risk finding anywhere. Any ECG changes, any adverse cardiac effects.
Because it is a retrospective analysis, no?
Yes, sir.
You should have found out, and then only you can tell that UHR is a independent marker for cardiometabolic risk.
That's why we have disclosed in the limitation so that we need a prospective arm to validate it.
No,
We have to follow it up.
Even in the retrospective study, did you take into the numbers between the of MI or adverse cardiac effect in the adverse events in the high UHR arm to the low UHR arm? There has been no slide on that.
No,
Then
sir.
how did you tell that UHR is a independent cardiometabolic risk factor without taking that into your primary outcome?
So we are talking about anti-atherogenic properties of HDL cholesterol. So that is the reason we are
Did
talking
you
about.
measure the carotid intima thickness?
No, something you need to, one, based on some clinical events, probably you would have measured and found out these patients with high ratio had some cardiovascular events, no? Or you should have looked at some risk factors like HSCRP or something like that. Or as Dr. Venko said, carotid intima medial thickness, which are the predictors of cardiovascular complication. So I think, okay.
Thank
Okay,
you.
doctor.
Nice
Thank you.
presentation. Thank you.
Thank you for all. This is a different presentation for latest stress-induced fields to control diabetics. Yoga is taken major part. I am going to explain the details. Modern scientific evolution, medical field recognized yoga by some of its valuable influences as human body and metabolism, considered it as a complementary medicines. All countries started as a complementary medicines. India, it is also well utilized for the yoga for the presentations. Even though we gave importance to genetic, diet, exercise, age, obesity, common cause stress is yet to be considered. When mind is calm, everything will be normal. If negative waves act on mind, creates emotional imbalance, disturb endocrine functions, cause stress, which is responsible for all psychosomatic diseases like diabetes, hypertension, and cardiac diseases. We had a study in our hospital to control stress, prevent psychosomatic diseases and diabetic hypertension. We take nearly 36 and 64% with diabetic, and among them 36 were trained with yoga. The result were after 9 months, the basal result and after the yoga results were compared, and see the difference how they improve in diabetics. So the fasting blood sugar was reduced to 10.8 milligram, whereas postprandial 20.2, HbA1c 0.8, whereas weight reduced to 2 kilos in persons doing yoga. Usually stress is the common cause for all psychosomatic diseases. Environmental stimulation via mind action on neurocenter creates psychogenetic waves, sensitize endocrines, stimulate whole visceral activity called stress reaction. This is the major cause for the diabetics. This is the pathway of stress. When any environmental stimulations acts on the mind, it orders the brain, whether it is positive or negative. Negative waves means it will improve the sympathetic nervous system, raise stress activities, raise heart rate, blood pressure, etc., etc. When it is a positive, the parasympathetic vagus nerves are stimulated, relax activities, reduce heart rate, and blood sugar, BP relax, and mind free. So, autonomic endocrinal metabolic changes are caused by strictly by the stress. So, for that, you have to control your mind. I want to know, where is the mind in your body? Anybody tells here, I will give 1,000 rupees. Because we want to control the mind, to control the stress, is it? Where is the mind in your body? Anybody? So, mind is imaginary part of the body, nowhere it is. Otherwise, it is called Atma, it is different. When it entered into the embryo, it will become a fetus. When it leaves the body, you become dead. That is the definition for the mind. So, since mind is imaginary, treatment also imaginary called meditation. For the meditation, you have to prepare the body is called yoga. For yoga, you must have a disciplinary life that is called Sadhvik diet. Sadhvik diet, yoga, meditation, otherwise called diet, exercise and mental relaxation. That is, every disease, your first line of treatment is lifestyle management, diet, exercise and mental relaxation. So, we have to emphasize that stress is the common cause for all the diseases and you have to control the stress by the following methods. It increases meditation, trains the mind to avoid environmental stimulation, reduce stress, relax and promotes brain's activity, tolerate anxious situations. Yoga increases the rate of glucose uptake in contracting muscles, similar to insulin's process that regulated by translocation of GLUT4 and plasma membrane. It also controls the insulin resistance by muscular action utilization, myosin lipid loadase, hepatoglycogen storage and free fatty acids utilizations. It also improves the metabolic benefits by sympathoadrenal axis, hypothalamic epithelial axis balance. And endothelial benefits activate vagal tone, reduce heart rate, blood pressure, oxidative stress and inflammatory cytokines, improve fibrinolytic endothelial disease. The final slide is, you see there are 7 mandalas, that is Mooladharam, Swadhisthana, Manipuraham, Anaham, Visuddhi, Agni and Duryam, 7 neurocenters. The same equally there are 7 endocrines and also you have 7 nerve plexus in your body. But all are the equal things, cerebral, pituitary, durium and cerebellar, pineal are there. There is a holistic relations between the meditation centers as well as the endocrine glands and also the nerve plexus. That is a psychogenic endocrine immune mechanism controlled by these holistic effects. Thank you for this.
But next time onwards, sir, such lectures need not be put in the free paper presentation, please. Thank you.